Hello everyone, I am Dr. Srishti Agarwal from the Department of Dermatology, and today we will be talking about basic skin lesions. So basic skin lesions can be primary and secondary. Primary skin lesion, basically the lesion is, the skin disease is characterized by the lesion. That is the primary skin lesion. Secondary is, it is the after effects of the exogenous or the endogenous factors and that occur during the course of the skin disease. Those are the secondary skin lesions. So in primary skin lesions, first we'll talk about the flat lesions. Flat lesions are basically, there is no elevation in the lesion, but there's just the color changes that can be seen. So such lesions are known as macule. So in that, it is a circumscribed flat non-palpable lesion. It can be circular, oval, irregular, any form, any shape it can be. It can be irregular, regular, any shape. And if it is more than 0.5 centimeter, then it is also known as a patch. So it can be hypopigmented. So for example, it is there in pityriasis alba, vitiligo, pityriasis versicolor. It can be hyperpigmented macule, so that occurs in melasma, that occurs in post-inflammatory hyperpigmentations. Also freckles, moles, those are all hyperpigmented macules. Then red macules, that is erythema. There is no skin change as such, just there is a little redness. So that can happen in a group of many diseases. Many contact dermatitis can also present like that. So next is a raised lesion. Raised solid lesion, if it is less than 0.5 centimeter, it is known as a papule, and if it is more than 0.5 centimeter, it is known as a plaque. So papule or plaque will have some surface changes also. They can be scaling, they can be crusting, they can be redness. So in that sense, the different diseases can be differentiated. Like if it is a pointed papule, then it can be pityriasis rubra alba. Then if it is a flat papule, that like we see in lichen planus, then it can be necrotic papule, that is there in pleva. Then blue-black papules can be seen in melanoma. Then pedunculated papules are seen in skin tags and neurofibromatosis. So papules, when coalesced together, can become plaque, or it can itself present as a plaque. Plaques are present usually in psoriasis, in lichen planus. In those we can see there are certain surface changes. Like in psoriasis, there is silvery white scales that can be seen, and in lichen planus, it is purplish, violaceous color that is seen. So next in raised lesions is nodule. Nodule is basically on the surface, it looks like a papule, but when we palpate it, we can feel there is a depth to the lesion. So in that, nodule is a circumscribed and palpable lesion that has a larger volume than a papule, is usually more than 1 centimeter in diameter and has a depth up to 2 centimeter, which can involve the dermis or the subcutis. It can consist of fluid, extracellular material like amyloid, inflammatory or neoplastic cells. Then nodules can be seen in keratoacanthomas, they can be seen in dermatofibromas and in lipomas. Next in raised lesions is pustule. Pustule is basically a papule kind of lesion, but it is filled with pus. It is a yellowish fluid that is seen in the raised lesion. So it is a circumscribed elevated lesion that contains purulent material. It occurs within the pilosebaceous unit, sweat glands or glabrous skin. It may occur due to some infections, although in some cases we can observe sterile pustules as well. So sterile pus is seen in pustular psoriasis and non-sterile in any kind of pyoderma, like in petigo, in other secondary infections of the skin. Then wheals. Wheals are basically, they result from the transient vascular reaction in the upper dermis, in which there is vasodilation. In addition to that, there is dermal or hypodermal edema, which leads to transient elevation of the skin, giving rise to a wheal. It is centrally pale with an erythematous rim that can be seen in it. So it is characterized by lesions of urticaria. In urticaria, the typical lesion is a wheal. basically will appear as a raised edematous looking red lesion. Dermographism is seen. What is dermographism? Is basically we will stroke the skin with a blunt object, and within 15 to 20 minutes that skin will become edematous and will become red. Basically a wheal will appear in that area. So urticaria is usually accompanied by dermographism. Then vesicles. Vesicles are circumscribed elevated lesions, but in these there is a clear fluid that is filled, and they are less than 0.5 centimeter in diameter. If they are more than 0.5 centimeter in diameter, then they are known as bulla. Usually it is a clear fluid, but also there can be hemorrhagic fluid and serous fluid, but never a yellowish fluid, because if it is a yellowish fluid, then it is known as a pustule. Then when the diameter increases, as I have told, it becomes a bulla. Then it can further be, the bulla can further be tense or flaccid. Tense means if we touch the bulla, it does not burst easily. So it is a tense bulla. So that appears in bullous pemphigoid disease, and if it is a flaccid bulla, then we say it is a pemphigus vulgaris disease. Then next is cyst. It is a closed cavity or sac lined by epithelium and filled with fluid or semi-solid material. It can be solid, soft, dewy, hard, or fluctuant. Sebaceous cyst is the commonest example that we will get here. Then next is purpura. Purpura is basically violaceous, reddish violaceous lesions that appear because of the internal bleeding under the skin. Petechiae and purpura occur due to the same problem, that there is a hemorrhage under the skin. Petechiae are just a spot size, purpura are a little bigger than that, and ecchymosis is basically bigger than even purpura, that is more than 2 centimeter in size. Then we will talk about the secondary lesions. Secondary lesions is basically the changes that we see because of the endogenous or the exogenous factors that occur on the diseased skin. So first we will see the scaling. Scale is basically a flat plate or flake or stratum corneum. Dry, greasy, laminated masses of keratin can be seen. And parakeratosis is often present histologically. Histologically, basically there is presence of parakeratosis, that is basically there is a defect of keratinization that can be seen if we do a skin biopsy. So the commonest example that we come across is basically fungal infection, that is tinea. In that we can see scaling. Another thing is psoriasis, in that we can see scaling, and ichthyosis also we can see scaling. So there are multiple types of scales, and according to that there are diseases that can be identified because of the particular type of scale that is present. So first is choleric scales that are seen in pityriasis rosea. Also they are seen in subsiding lesions of furuncle and miliaria. Furfuraceous scales are seen in pityriasis versicolor. Ichthyosiform scales are seen in ichthyosis vulgaris. Micaceous scales are seen in psoriasis. Limpet-like scales are seen in Retter's syndrome. Greasy scales are seen in seborrheic dermatitis. Trailing scales are seen in erythema annularis centrifugum. Then conflict-like scales are seen in pemphigus foliaceus. Then there is something known as coat of armor scales that is very commonly seen in harlequin ichthyosis. It is very characteristic of harlequin ichthyosis. Then plate-like scales can be seen in lamellar ichthyosis, and sandpaper-like scales can be seen in actinic keratosis. Then erosions is the second type of secondary lesion that we will talk about. It is basically loss of epidermis which heals without scarring. So it is just the superficial epidermis that is lost here. So the dermis and the subepithelial tissue is intact. It may or may not become crusted. Then next is ulcer. Ulcer goes a little deeper than the erosion. So basically there is loss of epidermis and dermis, often with the loss of underlying tissues. It heals with scarring, and ulcer has to be described with the location, margin, edges, floor, everything, because that determines whether it is a healing ulcer or a non-healing ulcer. Like the edges can be either punched out, rolled out, undermined, sloping or jagged, and the floor may contain pus or the granulation tissue or the necrotic material, and that all depends on the if it is healing ulcer, non-healing ulcer. Also the edges help us to describe whether it is a carcinoma or it is a benign lesion. Then next lesion is excoriation. Excoriation is basically described as abrasion, which is produced by mechanical means like scratching. Just the stratum corneum of the epidermis here is damaged, and there will be no scarring here. So it is characteristically linear because of scratching it appears, and more commonly it is seen in itchy conditions like atopic dermatitis, scabies. Next is scar. Scar is due to destruction by injury or a disease. Normal tissue eventually gets replaced by fibrous tissue, giving rise to a scar. It usually lies to the level of the reticular dermis. Hair follicles and other adnexal structures are destroyed within a scar. So the examples of scar can be an atrophic scar or a hypertrophic scar. In atrophic scar, it is thin and wrinkled scar, usually seen after acne. Acne scars are usually atrophic scars, but sometimes they can be hypertrophic scars also. Hypertrophic scar is elevated with growth of fibrous tissue. In hypertrophic scar, there can be keloid tendency also. Keloids are basically they look like hypertrophic scars, but they have pseudopodia like elevations on their sides. So because of that, there is excessive fiber tissue that holds them down, and because of that the tissue is very hard, and the patient can feel that the surrounding skin is stretching because of that keloid presence. Also, there are some cribriform scars that are perforated with multiple small pits. They are seen in pyoderma gangrenosum. Then crust, as we have talked, it is dried serum, pus or blood, and it is usually mixed with epithelial and sometimes bacterial debris. In layman language, if we talk, they are known as scabs. Then fissures. Fissures is a linear cleft through the epidermis or dermis. It can be single or multiple. It is usually found in regions which are subjected to frequent movement, like flexural creases of the thumbs, edge of the heel or the angle of the mouth. Then lichenification. Lichenification is basically, it has three components that have to be seen. There is hyperpigmentation, increased skin markings is seen, and thickened skin is seen. So basically three things have to be present to call it a lichenification. That there will be a plaque-like lesion, basically thickening of the skin will be there. Then there will be increased skin markings over there, and also it will be hyperpigmented. Then atrophy. Atrophy is basically decreased components of epidermis, dermis or the subcutis, and normally this atrophy can be seen in senile skin, and or the atrophy can be seen after scarring. So physiological atrophy is basically in the old age, in the geriatric age group, we see it as senile epidermal atrophy. Then there are some special lesions that are only described for a certain skin condition, that are not labeled as primary or the secondary lesion because they are special for that particular disease. So first and foremost is a burrow. Burrow is seen in scabies. It is basically a tiny tunnel in the skin which houses a parasite. It is a serpentinous tunnel that the mite creates in the skin, and at the end of it, if we take a histopathology, so at the base of that tunnel we will find the mite. In scabies, they may be of the size 5 mm. Longer burrows of around 5 to 10 centimeter can be seen on the feet in a creeping eruption that is known as larva migricans. That is a hookworm larvae that can be seen as, said as burrows, but burrows is usually described for the scabies. Then comedone. Comedone is something that we talk about in acne. They are dilated pilosebaceous orifice containing keratin and sebum. So there are types of comedones. that is open comedone and closed comedone. In open comedone, they have a conspicuous dilated follicular opening that is filled with an inspissated core of shed keratin. Melanin deposition and lipid oxidation within the debris may be responsible for the black color. So what happens, this keratin is deposited in the pilosebaceous unit, and as the tip is open, so this keratin goes oxidation and that gives a black color. So we call it as a black dot. Black head or black dot is said. So black head is basically an open comedone, and a closed comedone is basically the tip is closed. So they are generally smaller in size, less than 1 mm. Skin colored papules with no apparent follicular opening or associated erythema is seen. So they are white heads. They are white in color because no oxidation occurs because the tip is closed. So melia or the milium cyst is the next special lesion, and that is a white cyst with lamellated keratin. It is type of subepidermal retention cyst. It is basically sebum retention cyst that occurs. Then target lesions. Target lesions are classical of the erythema multiforme. They have 3 zones. A central area of dusky erythema is seen. Then a middle part pallor zone of edema, and an outer ring of erythema is seen. So dusky, then pale, then erythema, that is red, is seen. This is how a target lesion, it looks like a target that is seen. It is seen in erythema multiforme. Targetoid lesion, like resembling a target, but they will not have 3 rings, they can have 2 rings, that are seen in Stevens-Johnson syndrome. Then telangiectasia are small widened blood vessels on the skin. These are usually seen in fair skinned people. Small blood vessels over the skin can be seen, or they are seen in people who have a lot of epidermal atrophy. So basically the blood vessels of the skin become a little visible over the skin. Calcinosis is calcium deposition in the skin. It is commonly seen in calcinosis cutis. Then stria, they are linear atrophic depressions of the skin that form in the areas of dermal damage produced by stretching of the skin. It is associated with various physiological states like pregnancy, puberty, rapid growth, weight gain, and disorders that lead to hypercortisolism like Cushing syndrome. So stria can be either red, so then it is called stria rubra. It can be purple, and it can be white, stria distensi. So basically it has 3 stages of healing stria, and when it becomes pale, then that is permanent. Stria is difficult to treat as such. So these were about the basic skin lesions, primary, secondary and special skin lesions. So thank you so much.